today. So we've got Dr. Diana McIntosh, who's one of our paediatric oncologists and palliative care consultants in the Royal Hospital for Children in Glasgow.
What to do?
Does it make any difference? No,
Yeah.
it might just...
Okay. Can you guys see my screen just now?
Yeah.
Yeah.
Yes.
Yeah, okay. I'm sorry, you're going to have to bear with me because this is my first time presenting on Teams and sharing multiple screens. So what I wanted to just say was this is really informal. Please feel free to interrupt me at any time and ask any questions. Okay. So I'm going to talk about complex cancer pain and give a multimodal approach to pain management. Now, each of the headings, if you like, within this talk could be the basis of a whole day's teaching. And so I'm aware that I'm not going to go into anything in too much detail, but I have got a series of teaching sessions planned in the coming months that are going to go into each of these areas in a much deeper level. So that today, the purpose of today was just to give a sort of broad overview, how you would approach a patient with complex cancer pain, recognizing that we're not digging deep, but yet that we've got teaching sessions planned for this. So I just want to show you this YouTube video to begin with for a few minutes, because it kind of says in a few minutes what I could spend hours trying to say, and you still wouldn't get the gist of it. So here.
Diana, are we supposed to be hearing this?
Oh, can you not hear?
No, can't hear anything. Off the video, I mean.
Can you see the video? But you just
see the video. Can't hear it.
It's turned right up. You better know.
No, it's not. Whatever it is, it's not working.
Give me 2 seconds. If I can't work it out, okay. Right. Let me see. Can you hear that now?
No.
No. That's your content for the night. What video? Why things hurt. And really, the point of what I was trying to get, he talks about what happens when you get a painful stimulus to your leg, for example, when you're walking through the bush. And he talks about the afferent nerves going up, thick myelinated fibers going to the spinal cord, and then there's the postsynaptic nerves going up to your thalamic cortex, interacting with the frontal cortex. And then there's both positive and negative inhibitory and excitatory pathways going back down to tell you whether you're sore or not. And really, the point of him, he tells this story about he thought he was just being scratched by a stick or a piece of wood in the bush, and the next thing he wakes up in hospital having nearly died from a snake bite. He walks through the bush again a few months later, and then he feels this excruciating pain. And it was just a twig, and it was all about how the higher centers interfere with our pain. So it's definitely worth a watch, but I'll leave you to do that yourselves. Right, I'm going to share this now. Can you see this okay?
No, still seeing YouTube.
Okay, I've got my presentation up now. I don't know how that's happening. I am so sorry about this, guys. This is not my computer.
Don't worry, everybody else has been.
Two have gone down. I thought I'd be all organised and get this sorted.
You can try and sharing again.
Here we go. Right, can you see that now?
No, can only see you.
Right, okay.
Yes.
Yeah, brilliant. That's what happens when I try and be clever and do two different presentations.
No, she must have to do that.
Okay, see it now?
Yes.
Excellent. Right, here we go. Interrupt me anytime, okay? So I think this sort of slide summarize, I've shown it several times before, but I think it summarizes how and why I became interested in developing a specialist interest in palliative care. That absolutely curing children and young people from cancer is our goal, and that is always going to be our primary goal. And that we're going to treat all our children, but actually sometimes there will unfortunately be circumstances where we can't do that, and what we ultimately want to be able to do is always provide comfort no matter what the outcome may potentially be. And this is, as I was hoping to illustrate with the YouTube video, this can be incredibly difficult at times to achieve. No less because it is complicated, and treating children with complex cancer pain, whose pain is multifactorial in origin, is really challenging at times. Because of different causes, different treatments that they've received, both as treatment for their cancer, but as treatments for their pain with its own side effects. Which route is ideal? Sometimes we're limited with IV access, etc. Children and young people develop tolerance to some of the drugs that we've got them on, those limiting side effects, compliance. A lot of what we do in paediatric palliative medicine has a significant lack of evidence base behind it. And a lot of what we do is taken from adult practice. And as Linda will well know, we do go and ask our adult colleagues sometimes when we need help, but how that translates into paediatrics, we don't always know with their differing biologies. And also fear on the part of the child and the family, fear of pain, but also fear of us as clinicians and using drugs that we're perhaps not always the most familiar with. So how relevant is this to our practice? So this is a slide from a paper 20 years ago now by Joanne Wolfe, who is a professor of palliative medicine, pediatric palliative medicine in Boston, and she conducted this study before becoming a palliative medicine consultant. She was an oncologist, pediatric oncologist. Excuse me. And she wanted to look at what are the symptoms that people experience. So it will be no surprise to know that we've got fatigue, pain, breathlessness, lack of appetite, nausea and vomiting, constipation, and diarrhea as the most predominant symptoms that humans, not only children, experience at the end of life. And this top line here was looking at the amount of suffering patients and families attributed to their symptoms. So pain, almost 80% of patients perceived pain as significant in the last 3 months of life, with a significant amount of suffering from this pain attributed. And I think what's really interesting is that here in grey is when the symptom was treated successfully, but the dark line represents those that were treated unsuccessfully, is what that's supposed to say. So why am I showing you a slide that's 20 years old? Well, because unfortunately, pain and all the other symptoms we've described remain important symptoms at end of life, with significant amounts of distress attributed to them. And this is from the same group in the same paper 15 years later. And if we see here, pain was the most commonly reported symptom, and in blue is the high distress associated with that symptom. Here on the left is the last 3 months of life, and here on the right is the last 4 weeks of life. So pain and the attributed amount of distress with that remains a significant problem. So as clinicians dealing with these patients, we want to have a stepwise approach that we can apply to managing these patients. So if you ask yourself, what is pain? It can be sometimes quite a difficult thing to describe, but this is the International Association of the Study of Pain definition, and is what is used universally. So an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. But importantly, pain is always subjective. And another definition that I've heard is pain is what the patient says it is, which is not always easy to disentangle. So just in terms of background, I thought it was important to remind ourselves what are the different kinds of pain. So we have nociceptive pain arising from the activation of peripheral nerve endings that respond to noxious stimuli. So the classical example would be the stepping on a pin, and the pictures that we see with the different nerve conduction routes with that, which is what was being described in the YouTube video. And this can be somatic, so from muscles, joints, skin, or it can be visceral in internal organs. And then we have neuropathic pain, which is resulting from an injury to the somatosensory system, and this can include parasympathetic and sympathetic nervous system. And so I'm going to focus on mainly the first two of these, but we will in future talks be talking about psychosocial pain, or what's sometimes called total body pain, and then chronic pain we're not really going to address today. What I'd like to just have in our minds as we leave this talk is this sort of idea of multimodal analgesia, which is using, as it says, different modes to treat pain, which sounds very simple, but it really importantly, it is we achieve this by combining different analgesics that act by different mechanisms to result in either additive or synergistic analgesia, which allows us to reduce the side effects that we might see when we give just one drug. So for example, morphine, if the pain's increasing, we just go up and up in the dose, what we're going to get is probably less analgesic effect but more toxicity, which can be then reduced rather than increasing the morphine, adding in adjuncts, different types of analgesics. So we're going to, through the use of a case presentation, I'm going to talk about non-opioids, opioids, adjuvants that we might consider in adding into these two. I'm going to just mention invasive approaches that might be considered, and as I said, we're going to have a talk that's going to talk specifically about that. There's one planned for November time, not in this forum, but you're very welcome to join in with it. And then I'm going to mention the integrative therapies, or sometimes this is more an American term, but we would term as complementary therapies. But I think it's important to highlight that it complements the use of drugs. I'm never going to say that we should just be using this instead of drugs. And then just mention for completeness the World Health Organization principles around analgesic administration. So we've already talked about this. Where we feel a noxious stimulus goes up through this synapse to the dorsal horn, where it activates the postsynaptic membrane, and then the second afferent nerve to go to the thalamus, and then we've got descending inhibition. We've also got nerves that tell you to go and take your hand away from the hot or painful stimulus. And this is a gross oversimplification, as you will all be aware, but it's really just trying to highlight this point that the cortex is really involved, the periaqueductal grey matter, and the thalamus having various excitatory and inhibitory roles. So I think I've asked this question before. I'm going to try and not be very interactive, but I'm wondering if anybody remembers who this person is. So if I show you this, that might ring some bells. So this is Bethany Hamilton, who is a surfer in Hawaii, a world champion surfer, who was, I think about 15 years ago now, attacked by a shark during a competition. And she managed to get herself back on shore, onto the sand. She then collapsed and woke up in hospital with absolutely no idea what had happened to her. And she was, as you can see her board there, the shark took a bite not only just of her arm, of her board as well. And it took some time for this to register, and she describes not having felt any pain till many hours later. And I always think it's interesting to contrast that with a paper cut, and how painful that can be for several days, and just how important the higher centres are here on our interpretation of pain. So we've talked a bit about what it is. We've said it's a physiological event, but what I've tried to highlight is also a psychological experience. It's based on the interaction of all of these features with our mind. Our mind is plastic as well, and our perception of pain can change with time, so with persistent stimulus, and it can be individually variant or subjective, as we heard. So while I'm talking through this case that a number of you have already heard before, and will be familiar with our case, I think it's important that we just keep thinking about what were the challenges we encountered, what may we have added in, and what may we have done differently. So she was a young girl who presented when I was just first a consultant almost 5 years ago now, and she'd been having some back pain, treated with paracetamol and brufen, initially very effective, but increasingly became less effective, and it was waking her at night as well. I'm going to come back to this slide in a moment. So she ended up being scanned, and she had this pelvic mass, and this was her bone scan, and all the black areas here are showing widespread skeletal metastases and throughout her skeleton, including her skull, her long bones, her ribs, etc. So she ended up on diclofenac and Oromorph while we were taking all these, preparing her for starting treatment and awaiting the biopsy result. So what was really quite interesting is everything she was being prescribed was on a PRN basis, which I always think is good to remember. If we're prescribing an analgesic, to think of, should this be regular or should this be as required? Because sometimes PRN can mean patient receives nothing. So we should be aiming for around-the-clock analgesia when we've got significant pain, and that's in accordance with the World Health Organization guidelines on treatment of persistent pain in children with medical illness. So the first point is regular intervals, then adapting the treatment to the individual child. So very often when I go around the medical ward sometimes, or when we're asked to give advice from a supportive care perspective, when they say, oh, the child's on Oromorph, and we say, and is that effective? And nobody's asked the question, well, actually, I don't know if it's working or not. So we have to go in, and in the intervention we make, we have to assess the efficacy of that. We have to think of the appropriate route, and we have to think of this two-step ladder approach that used to be a three-step, but many of you are probably too young to remember. Our step 2 was dihydrocodone, and we no longer use that because of this concept of genetic polymorphism, where the public are completely randomly have different ways of metabolizing their dihydrocodeine. So they can be ultra fast metabolizers, in which case they're at risk of, even at low dose, having a respiratory arrest, which is what's been seen in the press and reported and contributed to the reason for us not using it, or ultra slow metabolizers who don't actually get any benefit analgesically from this, but yet have the side effects. So we've got our simple analgesics, and then we've got our opioids for moderate and severe pain. So back to our patient. She actually had, and I think this is a really important point to make for those of us who are just not that familiar with paediatric oncology yet, that chemotherapy is actually probably one of the best analgesics that we could give. This girl had a Ewing sarcoma with widespread metastases, and the best analgesic was 2-3 days into her VIDE chemotherapy, where she suddenly felt like she could breathe a sigh of relief, and we actually had to come down on her analgesics very quickly because she was becoming quite sleepy on very high doses that had, when she was in pain, had not made her sleepy. So we weaned her analgesics. We scanned her again after a couple of cycles. There was no change. Her bone scan did not show any change, but she remained really quite well. While she had presented, she hadn't been able to go from her downstairs to her upstairs, and she was mobilizing, showering. She managed to go back into school and see her friends. But we scanned her again when it came to decision regarding surgery, and there was no change in her disease, both locally or metastatically. So we made a decision to stop her chemotherapy, and we were making plans to start with second-line chemotherapy, which was irinotecan and temozolomide in this case. As we were preparing for that and having discussions obtaining consent, she suddenly presented with excruciating pain again. She couldn't walk, she couldn't go up the stairs, she struggled to get to the bathroom, and the pain was exactly as she had described before. She had a raised calcium, so we actually admitted her, brought her in, and gave her some bisphosphonate. So very similar to a little boy you'll be familiar with on the ward, who had been experiencing back pain. We've identified disease recurrence in his spine and widespread bony metastases, and you'll be aware that he had last week a high calcium, which was treated successfully with bisphosphonates. And with this patient, unfortunately, there was just an ongoing escalation in her opioid requirements. Thankfully, the boy that we're currently looking after has stabilized on that at the moment. So steroids, we added in steroids for this indication because it's thought that when we've got bony infiltration, there is some degree of edema as well. It's not very well understood why steroids work, but we use them both in paediatric and adult practice. But the exact mechanism is not entirely clear, although we know there are a number of studies that show steroids can help in neuropathic pain, thought to be something to do with anti-inflammatory properties of the steroids. What we try and do, however, is use short, sharp bursts and give high dose, then stop with ongoing effect usually seen, in order to try and minimize the potential side effects that we would see with high dose steroids. And we also gave her some lorazepam as well, which is again useful. Benzodiazepines have a definite role in the treatment of neuropathic pain, but in her own words, this was absolutely crap, made her feel rubbish and just didn't work. She was very emotional, understandably. She was preparing herself for second-line chemotherapy, and she'd basically be too unwell to tolerate this as a day case. She refused absolutely to come back for admission into hospital, and she was very teary. So in discussion with the psychiatrist, we started her on an SSRI, which actually worked well within a couple of weeks. Now, at this point, she was still unable to get up the stairs. There wasn't a downstairs shower, but they had a downstairs bathroom, and she was sleeping on the sofa. and struggling to make it to the bathroom. So we were needing something that could work quickly for incident pain, that had rapid onset and was, when she had used the bathroom, could get back and the effects would wear off. We gave her some sublingual fentanyl, which just wanted to draw attention here to the Scottish Palliative Care Guidelines, which are again aimed at adults, but we do sometimes use in young people as well. And this is just a handy chart on how to use the sublingual fentanyl in starting doses, that we can give a second tablet if the first one hadn't been effective after 15 to 30 minutes. And then if you were to use it again, you would go in at the higher dose, and then you can add in up. We got it up very quickly up to 800 micrograms, and we were really struggling to get any analgesic effect from this. Probably earlier than this, we should have added in gabapentin, but at this point she got onto gabapentin again for neuropathic pain. So assuming that with bony infiltration you're affecting nerve endings there as well, there was a real neuropathic element to this, and she described burning sensation, stabbing sensation as well. So we just want to just show where neuropathic pain comes into this very simplified diagram that we showed at the beginning. So when we've got persistent tissue injury that is not healing, we get excitatory input into this feedback. We get injury of the sodium channels directly as well, so you get ectopic firing, continually telling the brain this is sore. Then, because we've had this persistent firing, we get altered synaptic transmission as well. So the calcium channels here, which is where the gabapentin and pregabalin work, get turned on, if you like, and stay on, unable to switch off. And we also get reduced inhibition here, which is important in a minute when I talk about ketamine, because you get wind up phenomenon, but you also get turn off of the inhibition. So the brain would be switching off the mechanisms that tell you you're in pain. That's not happening when you've got neuropathic persistent tissue injury that's continually firing off signals to the brain. And this is where gabapentin, pregabalin are aiming to work at the presynaptic calcium channel synapses, which become dysfunctional with persistent firing. So as I said, they bind to the presynaptic voltage-gated calcium channels. They release a number of neuroexcitatory transmitters, including glutamate, noradrenaline, and substance P. And pregabalin may have a higher affinity for the voltage-gated calcium channels. But what they're both good at doing is inhibiting this allodynia and hyperalgesia that I'll come on to in a minute, which you sometimes see when you've had escalating doses of opioids as well as neuropathic pain. We've got no evidence for which is better, gabapentin versus pregabalin, but we tend to use gabapentin because it's cheaper. However, I would increasingly use pregabalin in these patients with whom you think there's going to be lots of drugs tried potentially, because it's only a twice daily dosing in comparison to gabapentin, which is 3 times a day. And a quick ready guide for converting gabapentin to pregabalin is using 1/6 of the dose of pregabalin compared to gabapentin. Day 1 having 50% of each, and then over the next 3 days do a stepwise increase of pregabalin and decrease of gabapentin. For teenagers in particular who want as little tablets as possible, this is a better option. So do opioids have a role in neuropathic pain? Well, yes, they do, is the short answer, without going into this too much. There is some evidence that opioids do have a role within neuropathic pain. It's just that when this pain persists or escalates, that we perhaps won't get the same effect by just simply increasing the opioids that we might with somatic pain or visceral pain. Sorry, here we go. So again, coming back to that point that I made earlier about chemotherapy being potentially used as for analgesic effect. Again, with the other boy that we've been talking about in recent weeks, he's been started on oral temozolomide, potentially with this thought in mind that it might improve neuropathic pain, it might turn off the bony infiltration, or at least halt it and prevent it from escalating rapidly. And that was the thought here, not with the intention of curing her of her disease, which we know was unfortunately going to be incurable. So at this point, she was having incredible side effects from her opioids. She was getting less time where she was able to mobilize, just even at rest, when she was having her breakthrough doses, and she was experiencing significant side effects from her opioids. She was really quite sleepy a lot of the time, and really not able to sleep. So we thought about adding in ketamine at this point. Now, ketamine is an excellent drug, and it's used as an NMDA receptor channel blocker. So the N-methyl D-aspartate channels, which have two functions. One is they're involved with the opioid binding at the mu opioid receptor, and also with this neuropathic element at the calcium channels. So a really good drug to choose where you've got lots of neuropathic elements to the pain, you're trying to use adjuvants, and you have escalating opioid requirements because of this NMDA receptor channel blocker. So it works both here at trying to reduce the excitation, but it also works here at trying to improve the descending inhibition that you get, which becomes turned off when you've got persistent neuropathic pain. And the other thing it does is sorry, I don't think I've got this slide in, it was in a different presentation, but it also acts at these mu opioid receptors and sort of upregulates them so that your opioid you can use a lower dose to reduce the side effects, but you get better analgesic effect by using an NMDA inhibitor. That's why ketamine is really good. You can use it orally. We can use the IV preparation orally, and it's used at much lower doses than is used in induction of anesthesia. And it was an incredibly effective drug for this patient. We were then able to wean slightly her opioids and reduce the side effects she was experiencing with that. However, what I did really want to do was convert her onto methadone. So the two classic NMDA receptor antagonists are ketamine and methadone. And the beauty of methadone is that it could potentially be used as a substitute to the opioids that she was on, whereas with the ketamine, that's just going to reduce the NMDA blocker, reduce the dose that we were having to give. However, I was a bit of a scaredy cat, didn't have Jonathan Downey here at that time, and we had not used it in any of our patients. I would have wanted her to come into hospital in order to start this because of our unfamiliarity with it. But she absolutely point blank refused. I also had a bed arranged for her at the hospice for her to go in so we could try her on the methadone, and I'd been in contact with the palliative care team down at Great Ormond Street in order to, and we had a plan, but she wouldn't go and I wasn't prepared to do this in her home. And the reason for the methadone being worrying is because of the very long half-life, the lipophilic nature to it, so it goes into it and can be stored within the fat stores within the body, and you have to titrate very slowly and carefully in order to get to safe levels without having the potential theoretical risk of overdosing and respiratory suppression. I know that you use it much more, Linda, in adults as well, that you'll have been familiar with it being used. And I think that it definitely has its place. I think we have to become more familiar with its use, but we have not needed to of late. And we've got Johnny, who's very experienced in using methadone, should we require it in the future. So to come back to this multimodal analgesic model, we've talked about the non-opioids, the opioids, and then the anti-adjuvants that she was on. So she was on the lorazepam, she was on antidepressant, the fluoxetine, and the benzodiazepines, bisphosphonates, steroids, muscle relaxants. We were hoping to get some effect from that from the lorazepam as well, and we actually changed on to midazolam in order to try and get that, because she was in so much pain, very stiff a lot of the time. And we've talked about the NMDA receptor channel, so ketamine really transformed our management of this patient. And at this point, we'd asked the adult team about whether or not we could have an epidural, but her pain was all over. And if you remember back to her scan that we saw, her bone scan, she had widespread cranial mets as well, from which she experienced pain. So epidural and an intrathecal was not an option for her, because in order to get this, you ideally need to have pain that is umbilicus and below. So she wasn't suitable for an implantable device. The integrative therapies, I think if we ask this patient, what is the thing that gives you most relief, she would say, having my dad massage my legs, because the pain was predominantly in her legs, and she had sort of almost restless legs syndrome as well, and she said massage was really good. So went back to the pain team and asked them if they could think of anything other than having a masseur booked into the house and sitting there with her all 24 hours a day, anything they could suggest. And they said, well, why don't you give her a couple of TENS machines that she can use? And in fact, she found these TENS machines incredibly helpful. And I'm just going to talk a little bit more about these integrative approaches, which seem very I talked about a lot in America. They're very American, but I think we have to remember that they have a significant role to play in the treatment of these patients. Unfortunately, we did have some degree of stability for several weeks, but she had then a sudden escalating opioid requirement, and we needed to increase her ketamine as well. I was asked to go and see her one day out of the blue. I'd seen her 2 days previously. She had massive proptosis, suddenly woke up one morning with massive proptosis. And it was clear that she had disease behind her globe, pushing it forward. So we managed to get her in for an MRI scan at that point. We, under great duress, managed to make her stay overnight for a high-dose methylprednisolone course. And she went for bilateral orbital radiotherapy. Again, not classically your first thought, but important to consider the role of palliative radiotherapy in patients who are experiencing significant pain. And again, the boy we alluded to earlier is undergoing palliative radiotherapy for, same indication, help with pain. And Ben Fulton, our clinical oncologist who's based over at the Beatson, is going to talk specifically about palliative radiotherapy at one of our educational sessions coming up, and I'll circulate the programme for that soon. We stopped her as toposide. She was starting to need, she had myelosuppression and was needing bone marrow and blood product support to support her bone marrow. So we decided it was clear disease was progressing and it didn't merit continuing on this any longer. We had a just-in-case box we prescribed and put into the house. Thankfully, it was probably done far too late, but important to consider early on anticipate what symptoms and what drugs a patient might potentially need in the home setting, and have arrangements in place with a symptom control plan to go along with these in the event that our oncology outreach nurses, district nurses who sometimes support them, are able to use in an emergency. And I'm glad that our pharmacy staff were so obliging and were able to get that together for us on a Friday afternoon, and the outreach nurse took it in on the Saturday, because on the Sunday she was starting to twitch, and she actually developed her first tonic-clonic seizure requiring multiple doses of midazolam to arrest that. Went in to see her the next day, and we started her on the midazolam infusion. And at that point, we asked for a meeting with the GP and the district nurses, who'd already been very closely involved, just to talk about, if it was clear that we were entering a more progressive phase, and we were not going to be able to use the routes effectively that we had been, and she was going to start needing subcutaneous medication. We transferred her at that point onto diamorphine infusion, and she ended up on all of these medications. And we stopped her potassium supplements at that point as well, and we stopped anything orally we could, but we would actually felt that everything there on this list was necessary. I'm just going to pause a minute and see if anybody's got any questions or any suggestions regarding this cocktail of drugs that we ended up on, or the process we went through.
Is there a difference between using morphine or is it just
Sorry, Susan, ask me that again.
morphine v oxycodone?
So I think we're increasingly using oxycodone more. I think the most important thing is using what you're familiar with. What I haven't included with this patient is that we did do an opioid rotation, and she did go on to oxycodone at the point before we added in the ketamine. Slightly different side effect profile, perhaps less constipating, but I think it's important to use one and be familiar with it. The other thing is that when you see tolerance developing, it's important to consider a rotation of opioids, because they do work on slightly different opioid receptors, and you're able to then exploit this phenomenon that is called opioid incomplete cross tolerance. So you're able to switch using an equivalent dose, reduce that by 25%, and then start at a lower dose. And at that point, you usually should see, if it is opioid sensitive pain, you should see an improvement in the analgesic effect with a reduction in side effects. And I don't think that we do that often enough in our management of these patients with complex cancer pain. So I think it's using what you're familiar with. I don't think that one is particularly effective in this scenario over the other. But consider rotation of one to another once you start to see some tolerance or side effects. And we can talk about that in much more detail. I've got a whole talk on that as well. A consultant I learnt from in the States on a multimodal analgesic course always talked about it's the difference is almost like the difference between Pepsi and Coke. Or Johnny here likes to use the Iron Brew. I don't know what you would compare Iron Brew with, right enough, but yeah, does the same thing, but some people prefer one over the other, and individual patients prefer one over the other sometimes too.
Do you need to do much monitoring of like LFTs and renal function when you're on multi-drugs and it's palliative? Is there a bit of a balance?
Yes, so you're absolutely right, and then we're always addressing that, just as we're always addressing the need for polypharmacy and only having drugs in there which are A, required, and B, effective. And you do get to a point. So for example, when you were asking there about the blood test, for example, the Sandoke, we had been monitoring her electrolytes, and we've been monitoring her full blood count because of the etoposide. Because we actually brought her in for a blood transfusion one day, and we gave platelets in the community, which we do very rarely, but we did do it for her when there was active bleeding. And it's just striking the balance, is always going back to, well, what are our goals of care here? And at that point we stopped. When we realised we were going on to a driver, we were on all these drugs, we stopped doing any bloods. And sometimes with our patients who've sometimes had bloods taken for years, this can be a big step for parents, and they struggle with that. But it's always thinking about, right, well, what are our goals of care? So had we found out that this girl had a very low potassium or a high potassium, were we going to act on that? No. So why were we checking it? So it's always refocusing your mind to, well, why are we doing this? And it becomes even more important in this situation, in this scenario, only doing things that are required. And I would say the same goes for monitoring at this point as well. We have patients sometimes who are on SATS monitors, etc., and it can be difficult for them to, and they're used to being in the hospital settings. Many patients have been in ICU, so they've become fixed with that idea, and it can be hard to wean them off. But again, are you going to act on it? And sometimes it's better to get parents and family to look to say, right, let's just look at our child in front of us and act accordingly.
I was just going to, I've been out a minute or two, Diana, so apologies if this has already been asked. But how was this list being delivered? Did she have a driver up, or did
she ended up on a driver initially? Once she fitted and we started her on midazolam because she was really twitchy, we then converted her opioids to diamorphine, and the district nurses and the GP were actually amazing and administered breakthrough doses subcutaneously out of hours. And we also still had the enteral route and were able to give her drugs via an NG tube as well.
Yeah.
It was very distressing to see that she was on, and I put them all up there. She wasn't necessarily all on all of these drugs at the same time, but it was the cocktail that she had been on in the last weeks and months of her life.
Yeah.
Anyone else want to ask me anything about this, or I'll just quickly nip through the last few slides. Any other thoughts about what we could have considered? I mentioned the methadone, which I was really desperate to get her on, and I think could have been very effective here, but we didn't end up doing it.
I was just going to say, did you a patch?
Yeah, we tried fentanyl patches. She took it off and threw it at us.
Yeah.
And it was difficult. So the issue being that we were it was not, we seemed to be climbing the ladder the whole time, Linda. We never really got her to steady state. So that's the important thing with fentanyl patch. For those who are not familiar, is that you ideally would like to get them to steady state, or stable on the analgesia, and then convert them to fentanyl. And that was one of the opioid rotations we tried much earlier on, but she was having to go up and up and up, and it was difficult to maintain her on that. I presented this case at a palliative and anaesthetic, paediatric anaesthetic pain club, and suggestions were of conscious, unconscious, make her unconscious, sedation, up the midazolam infusion, terminal sedation really, and to try and alleviate her from her pain. And somebody also suggested IV propofol, which I know has been tried with another patient recently in ICU, but that's all very well when you're in ICU, not something that we would undertake at home. But she was incredibly challenging, and it was very distressing for all to see how difficult she was. We had the adult hospice doctors and the adult hospice palliative care team involved as well. They kindly came and reviewed her. I think called upon every contact I've ever made to manage her. So it can be complicated, but there's I've just mentioned that, and then methadone said here as well about can be really useful in neuropathic and nociceptive pain, end of life. Linda, I'm not sure if you want to say anything about methadone. Did you use that? For those of you who don't know, Linda worked in the adult hospice.
Well, yes, we did use it, and people, obviously always came into hospital to have, or into the hospice to have it started. It wasn't ever anything that was started at home when I was there, but it was just done when they came in. But personally, I don't have a lot of experience with it.
And then they use it all the time. Some people in this scenario use it first line.
Yeah.
They thought I was just when I decided in a course in America, why did I not use it? But anyway, I'm just going to go through this, but it's the unpredictability and the half-life. It can range from 12 to 200 hours, dependent on the individual patient, and the analgesic effect is significantly shorter than the half-life. So with Oromorph, for example, you can give that, and patients can be a bit sleepy, but it starts to wear off within 4 to 6 hours. If you've got something that can last in the system for many, many hours, you'd be less likely to do that in the community setting. So I told you that I had far too much to talk about. I think I just wanted to finish on talking about integrative medicine, or this multimodal approach, which can be used to address all aspects of pain, not just physical, but emotional, social, and spiritual as well. And we can have further, deeper discussions about these different aspects of pain. Well, I had the opportunity to go to the States and visit this integrative medicine pain clinic, and is beautifully sponsored by Avida. So you can imagine every room had a different theme with all these beautiful surroundings, and you would instantly think that you'd go into there and feel less pain. I would imagine. Someone talked about having Tunnock's tea cakes potentially decorate a unit that we might have here in Glasgow, which I don't think would have the same analgesic properties. But they had doctor and nurse, and they had psychologists, which I think is incredibly important. And there's a clinical trial that we've been talking about that's potentially going to cause a lot of pain in its recipients, and I think this is a really important thing to consider about empowering the individuals, particularly young girls or teenagers, like the girl we talked about, trying to use alternative approaches, non-pharmacological approaches. I know Dermot Murphy calls this the magic woo-woo, but I think magic woo-woo with lots of drugs can be potentially very effective. The other thing I would suggest you have a look is anybody, Linda, you might remember a patient we had who used the magic glove technique whenever she was coming to get bloods, and her mum would use hypnoanalgesia, which is a fun thing to do, and it has got an evidence base behind it as well. I would never say go and use analgesia instead of opioids, but good to have some other things, and to try and give some control to parents and to children as well. So the magic glove. I'm talked too much about the other stuff, so I'm just going to whiz through this, but there is significant meta-analysis level of evidence that hypnosis can be highly effective, but also things like using your favourite place, so helping children to have like what you would talk about as a special place, and what that sounds like, what that feels like, what that smells like, that they can take themselves into when they're in this state of great distress. Maybe ketamine would assist that process, but yeah, there is significant evidence behind some of these. There's a role for physio as well, aromatherapy, and acupuncture we have used in the past as well. There's a patient I remember well of Dermot Murphy's who had complex neuropathic pain, following antibody, one of our first antibody patients, and who subsequently got repeat antibody, and she had significant hyperalgesia from her opioids, and acupuncture and yoga were very effective for her. And one of our anaesthetists here can deliver that if we need him to. Music therapy and massage therapy. Okay, I'm just going to leave on that. So really what I'm trying to say is that we don't often within our culture, within our department, think of the non-pharmacological approaches, but I think it is something that we should give more thought and consideration to. And I hope what I've tried to do is give you an overview, knowing that more in-depth discussions will come about specifics. We've got neurobiology of pain, we have neuropathic pain talks, and we have methadone, and we have opioid rotation talks planned for the next few months. So I'll definitely circulate those to you. With dates and speakers. So we've got a couple of speakers from Great Ormond Street delivering those as well, which should be really quite interesting to hear a different centres approach. But what I wanted to leave you with is back to the basics. Although we can face some really tricky problems, at the end of the day, this approach can be applied to every single symptom that we're dealing with. We need a history and examination in order to help us develop a differential diagnosis, and we need to work through that differential, always thinking and reassessing the efficacy, and not just start piled one drug upon the other, but take something away. If it's not working, stop it and try something else. Although sometimes we need a combination of different drugs working in different ways in order to reduce the symptoms. So exactly the reason why we give multiple antiemetics when we are potentially going to induce chemotherapy, induce nausea and vomiting. So history and exam, identify the cause, you consider pharmacological approaches, and always consider the non-pharmacological approaches as well. And I'm sorry about the technical hitches earlier with my YouTube video, but go and watch that later. It describes in a much better way than I can the neurophysiology. Thank you. Any questions? Stunge into silence. It's very hard with this when you can't see anybody when you're speaking. It's hard to generate discussion.
Thank you very much for it's been actually offered quite a lot of insights. And
good.
Good.
Okay, Albert, you're very welcome. And if anyone has any other questions, please feel free to grab me, and I'll also let you know of the teaching sessions that we've got planned for the near future.
Okay. Thank you very much. This session will be recorded and uploaded on our YouTube channel as well. I'm trying to get a link to the other
Thanks.
Okay, thank you.